So during routine hip ultrasound, at times there's patients who report a pain in the front of the hip or the side of the hip related to a clicking or a popping sensation or a giving way sensation. So sometimes they have soft tissue that's causing this sensation for the click outside the hip, and that's where we come in handy as sonographers. We can see all the soft tissues. At times the cause of the click will be intracapsular. So snapping hip syndrome is the name we give to this. It's also known as coxosultans, which means dancer's hip, because it's more common in dancers. And clinically, it's characterised by an audible or a palpable snapping sensation during movement of the hip. So there's multiple etiologies to investigate and multiple anatomic structures that can be the source of the snapping sensation. And in this talk, we'll go over some of those. So we need to learn that there are causes that are anterior and lateral for the extra-articular snapping hip. So obviously it's very helpful. We can ask the patient to put their finger on where the snapping's occurring, and we can try and feel it during movement as well. So it's important to mention that there are also many cases of people with snapping hip or snapping tendons that are minimally or completely asymptomatic. So we're investigating painful external snapping hip. There are non-operative treatments for people, including physical therapies and remedial therapies, but there's also surgical techniques for chronic cases which are involved at the point of, when the patients reach their limits and we need to lengthen the tendons. Surgery can lengthen the tendon or excise burses and debride when things have become chronic. So it's very important to understand that there are some causes that we can't see because they're in fact intra-articular. If they're external to the hip, then the beauty of ultrasound is we have dynamic techniques and we can try and demonstrate the source, particularly with the cine loop function or video function. There are many activities that you should probably be aware of in case your patient comes in and says, hey, I play this sport. And they're things like recreational ballet dancers or competitive ballet dancers. Weightlifters suffer a lot from this, soccer players and runners. In terms of competitive ballet dancers, nearly 90% of them report snapping hip syndrome and 80% have a bilateral involvement. So you imagine when they pull their knee up in front and rotate or externally rotate the hip out to the side, that sort of abduction, external hip rotation with the hip flexed to at least 90 degrees is typically where they will get their click. And the cause of the clicking can be the iliopsoas tendon in the front, but it can also be around the side, the iliotibial tract or band, and the gluteus maximus, its anterior edge just sits near the greater trochanter and can be a cause as well. So as part of our examination, we're looking for tendinitis, so we can compare our iliopsoas tendons. We can look for the iliopsoas bursa in comparison with the other side. We can look for muscle tears in the gluteal tendons or the iliacus. The role of ultrasound is to look for these two subcategories. In terms of extra-articular snapping, we have both external and internal. This is where the terminology gets a little bit confusing. So the external snapping is also called lateral snapping, and that's where thickened portions of the ITB or ITT or the fascia lata or the anterior glute max tendon snap over the greater trochanter, and it occurs during flexion or extension or external to internal rotation. The iliopsoas can also roll over the medial fibres of the iliacus, and we'll be seeing some examples of that, and it can snap back, so it's normally a very mobile tendon. Then we have the internal snapping hip. So internal refers to an anterior cause. So the iliopsoas can rotate on its axis, or it can snap as it rolls over a bony prominence called the iliopectineal eminence. The pelvic brim can also be a source, or little bony ossicles and anterior labral osteophytes near the anterior femoral head. So a lot of patients will report a clunk when they're swinging their leg, taking the first step out of their car, or they're standing up from being seated, or they're running. And these are all the sorts of clinical history that are helpful to us to direct our study. In terms of the intra-articular causes, there's obviously loose bodies, so little bony fragments that can float around inside the hip joint. But the term intra-articular is sort of gradually phasing out because we're starting to know that it's these loose bodies that are the cause, and they're formed during the process of synovial chondromatosis. The causes inside the hip for clicking and pain can also involve ligamentum teres tears and also labral tears of the hip. So the anatomy of the iliopsoas. So I'll give you a minute to look through the diagram and just get oriented. Obviously this is the pubic symphysis at the front. We have the hip bones, the right and the left, and the buttock is back here. All the muscles are labelled for us. You can see femoral artery and vein here, pectineus here, obturator externus. This is our iliacus muscle, our sartorius, our rectus femoris, our tensor fascia latae, which is different to the tensor fascia or the ITB, and gluteus minimus here. The iliopectineal eminence sits beneath the iliopsoas and the iliacus, and the iliopectineal eminence is just higher in location to where the femoral head is. It's basically where the iliac bone externally meets with the pubic bone at a small little elevation. And that elevation acts like a pulley for the iliopsoas tendon. So this is the iliopectineal eminence here. So the iliopsoas tendon, this part here, is a musculotendinous complex, and it arises from both the psoas major muscle and an accessory tendon from the iliacus muscle, and muscular fibres of the iliacus as well form this iliopsoas tendon. So the psoas tendon itself, so this part here, originates above the level of the inguinal ligament and hip joint and inserts directly into the lesser trochanter. And occasionally it's a bifid tendon, so we'll see this on ultrasound. It can look like two portions. The iliacus tendon, which comes from over here in this iliac fossa, is obviously more lateral, and it fuses progressively into the psoas tendon. The most medial fibres of the iliacus fuse with the iliac tendon, whereas the lateral fibres out here, they're not really part of this complex. So the lateral fibres, they go directly onto the lesser trochanter. And sometimes they can be seen to overlie the anterior hip in our standard anterior hip view. Psoas major, if you're not familiar with your anatomy, it originates from the transverse processes up here of the lumbar vertebra, from say T12 to L5, and it inserts technically into the lesser trochanter. There's also a psoas minor tendon that can be present in some patients, about 60%, and that will arise from your T12 and L1, so it's a smaller muscle and a bit higher, and inserts sometimes onto the iliopectineal eminence. That's revision of anatomy. Here it is in a cadaver, so we can see psoas, we can see iliacus, inguinal ligament, we can see pectineus here, and sartorius arising from the ASIS. And this is our iliacus fibres extending down, and the iliopsoas tendon sits in here. So the iliopsoas tendon, we're going to find it if we're looking deep to the femoral artery. Sometimes if we slide our probe in from lateral to medial, we can use the sartorius in the iliacus as a muscular acoustic window to the psoas tendon. When we're in transverse on the groin crease, down here, the structures we're going to see laterally are iliacus sartorius, and in the deep part of our image we can go looking for this femoral head. It sort of looks like a rainbow. So they're good landmarks for just getting started for clicking hip. So there's different versions of clicking that can come from the iliopsoas tendon. For number one, they can flick up and over the medial fibres of iliacus, like so. They can also slide over the iliopectineal eminence, like so. They can rotate vertically on their axis, just sort of flicking on themselves, or they can flick over ganglions, labral cysts, and capsular thickening, which can occur sort of slightly more laterally. The bursa is located deep to the tendon, so if we're guiding injections, we can guide through the muscular window of iliacus, fairly safe, straightforward path to the bursa. So we don't want to see the tendon lifting up off the bone, as that can be an indicator of bursitis. So it's good if you can coach your patient how to do it first. So obviously the first position is up to flexion, so I just call this tabletop. Then you're going to have to try and find the tendon. And then we come out to the side, get them to pause, and then they do one big circle like that. And try and, palpate it. So you'll feel the click under the transducer, which is helpful. So let's see if we can find it. So obviously your body needs to be high, because otherwise your elbow's just going to run into their leg. And left hips, if you've got a spare person to work the machine, just stand on the other side. I just pull it out from the wall. So it's a two hands job. So there's the femoral artery, iliacus lateral fibres, iliacus medial fibres. That's too low, that's femoral head. We're going up, there's iliopectineal eminence, and we want to be sort of lower than the AIIS. So this is our starting position, and I'm now putting more pressure on the outside of the camera just to make the tendon nice and bright. So we're ready to go. So we're going to use my left hand. Now, my left hand's just guiding, my right hand's putting the pressure. So if you can bring your knee up to flexion. All right, now can you see our tendon has popped right up off the bone here? Okay, now we're going to bring it out to the side and just hover. It doesn't matter if you lose it momentarily, so I've just swapped my grip to the inside. So the bit we want to see is now. Going to get you to do one smooth movement and adduct the hip like a breaststroke kick. And you could feel that under the transducer. So I'll wind it back so you can see it. So we can trim that and we'll play that little video. So, nice example. Now we'll run through the anatomy on ultrasound. So as you place your probe towards the midline of the hip and you're on the groin crease, we can see certain structures. So laterally we're going to see the iliacus, and the AIIS is the anterior inferior iliac spine. So we can move down from ASIS, seeing the iliacus muscular fibres, the inguinal ligament over the top, and we can come south until we see the iliopsoas tendon. So we're on the iliopectineal eminence there. You can see femoral artery bouncing on the left, and that's the AIIS. Any lower and we hit that femoral head. Don't know if you just saw that little rainbow, but we'll play it again. So we're sliding down from ASIS, visualizing iliacus, a little more medial to this and more caudal, more south. We see iliopsoas tendon overlying the iliopectineal eminence. A little further south of this, we see femoral head. And we want to sit just above the femoral head, ready to do our dynamic assessment. So a normal patient performing a movement called the Faber test, which is flexion, abduction, and then returning back like a breaststroke kick. Obviously the iliopsoas tendon is designed to physiologically move up and away from the bone. So we'll have a look at what a normal patient would look like in terms of the smooth gliding we would see. So if you watch this tendon here, you can see it shoots up and then circles around, returning quite smoothly back to the iliopectineal eminence. So this is during flexion and abduction. It's moved up and away from the bone. It's shot right up here, and then it smoothly circles back down and around. Just to orientate you, this is iliacus over here, femoral artery here. Okay, so that's a normal patient. Obviously not everybody that clicks is going to be symptomatic, so just because it clicks doesn't mean a patient is going to suffer pain. But when we're examining the cause of a click that's obviously some concern clinically to the patient, these are the tests we perform. We'll have a look at another case now of a click that occurs bilaterally. In this patient, it occurs on a different part of the movement. So normally you get it when they're returning their leg back down to neutral, so in the breaststroke kick. In this patient, it's just slightly different. So we can see our landmarks here, the rainbow sign. We're moving just above that, and you need to angle up slightly so that we see that tendon echogenic. Here's the first part of the movement, the flexion. You can see the tendons moved laterally. Now the abduction and coming back for the circle around. Keep our eye on the tendon. There's the little pop. And we haven't quite returned to neutral yet. So the little pop is just the tendon sort of quickly snapping back down onto the iliopectineal eminence at this point in movement. So about now. Yeah. So just a little pop. So if you see that, we can report, the cause for the patient's click was the iliopsoas tendon during whatever movement it was. Okay, so the other causes, obviously, there can be a little actual sort of bony prominence that the tendon clicks over on that iliopectineal eminence. And often there's a bifid iliopsoas tendon. So you can have these two heads and they can sort of flick over one another like this, snapping down onto the bone. So there's a nice little paper written by Deslandes 2008 that I can give you the reference for. When we look at the anterior joint in these patients, we expect to see something like this. So in longitudinal, with the probe placed on the AIIS, we see the iliofemoral ligament, which is the capsule. We see the femoral head, and we can see part of the anterior labrum of the hip, which always looks triangular and echogenic. So this is a nice normal looking hip. So this is the anterior acetabulum here, and obviously the joint down in here, and the cartilage over the femoral head. In transverse, we shouldn't see this sort of a bulge. So this is the iliopectineal eminence here meeting the femoral head. So we're in transverse at this same level. We should see femoral artery, psoas muscle, and nice neat iliopsoas tendon. But here we can see that there's some capsular thickening, some degenerative change around the area of the labrum, and these little anterior acetabular rim osteophytes. So these are quite common. And you can see how this bowing up of the capsule could cause some irritation to the tendon and even cause the tendon to flick. In other patients, when you're in transverse, you see femoral artery, femoral nerve, psoas muscle, iliopsoas tendon, medial fibers of iliacus, and then these little cystic changes within the area of the labrum. These can be little paralabral cysts. So this can be the cause of the pain, and in these sorts of instances, yes, you might witness a click, but it would be also good to be performing an MRI to look a little closer at the internal structures of the hip. So we'll have a brief look through some case studies. This was a 16-year-old girl who was very keen on hurdling, and obviously training, she was feeling a click but also pain sensation. So you can see just a nice easy dual B-mode image. We've looked at the normal side at the level of the femoral head, the femoral capsule here, for the joint capsule, and then a little iliopsoas tendon looking very flat and normal. And on her symptomatic side at the same location, we've got the iliopsoas tendon looking a lot larger. So using a cross-sectional ellipse tool is very helpful to be able to show that one's now 0.3 centimetres squared and the other is 0.2 centimetres squared. And then here's her dynamic assessment. So we see the tendon circling up and down and around. That was a normal loop, and now we've been able to capture the click. So if you watch on this right-hand video, now, interestingly, the first few times we performed this, we were unable to reproduce the click. And so we said, look, what position do you really get this click in? She said, well, I have to be standing. It's when I'm hurdling and I bring my leg over the hurdle. So we had to change track and stand this young lady up. And with standing up, she was holding the wall. We had to reposition the ultrasound machine to get a good look. And so if at first you don't succeed, keep trying, because we were able to then change what we were doing and see the click in a different position. Again, it was still the same flexion, abduction, external rotation, but it took a little while before we actually could witness the little clunk of the tendon as it snapped back down onto the bone. And that was the cause of her pain. And obviously there'd be a lot of tightness in her hip flexors if that's the activity she's engaged in a lot of the time. This was her corresponding x-ray. So the report read something like this. The iliopsoas migrates superolaterally over the medial fibres of the iliacus. It then clicks again when the patient is internally rotating. The iliopsoas tendon is thickened when compared to the left side. Rectus femoris is normal in appearance. There's no significant hip joint effusion, no paralabral cyst, no significant distension of the iliopsoas bursa, which is beneath the tendon. Features in keeping with external snapping hip syndrome. So you can see that we've been able to demonstrate the cause. So here we're looking at a left hip. We'll just run through the anatomy. The iliac crest is superiorly, and obviously the knee is inferiorly. We can see the ASIS, and the iliotibial band is here. It's a thickened aponeurotic band which runs all the way from the iliac crest all the way to the knee. And it's important to know that this ITB is not fixed to the greater trochanter, it's freely mobile, and it's connected intimately with your TFL muscle, your tensor fasciae latae, and also the gluteus maximus muscle posteriorly. So they form the superficial layer of the hip. A bit like in your shoulder, you have the deltoid overlying a rotator cuff. Well, we have this layer overlying the rotator cuff of the hip. So we would say that the ITT or the ITB, whichever you like, originates from the fascial components of the tensor fasciae latae and the gluteus maximus, and also gluteus medius. So we have 3 layers in the ITB, which I'll describe now. So we need to think of every muscle as a piece of meat which has fascia running over the front of it and over the back of it. So the fascia latae muscle is going to have fascia on top, fascia underneath. When the muscle terminates, those 2 layers of fascia come together and form this part of the aponeurosis. In the ITB, we have a superficial layer, an intermediate layer, and a deep layer. And the deep layer is down over the greater trochanter. So if you get time, read an article by Putzer, 2017. It's really good to explain the layers of the ITB, but in the interest of time, I won't discuss it in detail here. I do want to show you what we're looking at here. So if we were to dissect, this is now on a left hip as well, dissect this interval here between the TFL and your rectus femoris. So we've just reflected that fascia off the TFL. S here is denoting the sartorius, which is coming off the ASIS here. We see the rectus femoris muscle. This is probably just the direct head, which goes straight to the AIIS, as you may know. The reflected head's probably deep in there. We can't quite see where it's going. So the deep layer of the ITB is where these green arrows are. We need to resect those or split those open to see the hip joint and the hip capsule. The yellow arrows here indicate the lateral femoral cutaneous nerve position. Behind the TFL, we have gluteus medius back here, just the muscle belly. Lower down, of course, we're going to see gluteus maximus inserting here. So as I said, the ITT is a 3-layered structure. We have the superficial layer arising from this yellow section. Just to orient you, this is sacrum, this is ASIS, so we're looking at the right hip where minimus and medius would insert. So this is where your iliotibial band or tract comes from. But then there's that deep layer. So the red here indicates where the tensor fasciae latae muscle, which is this one, has its origin. And then, as I said, the fascia encases that muscle. So on the top side and on the deep side of the muscle, it has fascia. So the deep side, the fascia would arise from just beneath this red area here. So on your right hip, if you had an anterior view on a cadaver, we'd see ASIS here, inguinal ligament stretching over here to the pubic tubercle. We see sartorius, and then out here, this is the ITB, big fascial layer, which has its origin here on the yellow. This is the superficial band. You can see how it overlies the tensor fasciae latae muscle, which is in here. And this little asterisk here is on the intermediate layer of the ITB. And that would then come together down here to form the tendon of the tensor fasciae latae. Then there's a really deep layer. And the deepest layer of that ITT, the three-layered structure, originates here. You might be familiar that this is the same region where your reflected head or your indirect head of the rectus femoris comes from. So the one that's over the hip joint capsule, as opposed to the direct head, which comes from AIIS. So next we're going to look at a dynamic ultrasound case where we could successfully see a translation of the iliotibial tract over the gluteus maximus. The patient had an audible snap and with pain, and in this case the patient had to stand for us to reproduce the snap. We could have tried flexion with an adducted hip moving to an extended hip, but this didn't quite work for this particular patient. And if you're familiar with ultrasound anatomy, when we look at a transverse lateral hip, we have our probe positioned here over the greater trochanter, and we see a little bump in the bone. And that bump is the transition between the anterior facet, where our minimus inserts, and the lateral facet, where our medius inserts. So if we were to look at the tensor fasciae latae muscle, then deep to that, keeping the muscle up off the bone, is the gluteus minimus. And then we see our iliotibial tract connecting TFL, superficial layer, back to gluteus maximus. And then under that, obviously there's a bursa. So in this next patient, we're going to be looking for a click that's occurring out here at the greater trochanter. This is the posterior facet, which is largely exposed. If this image was to move higher, we would see the second band of the medius, which is the posterior-superior facet. Yes, there's also subglute min bursa and a subglute med bursa, but less commonly we see fluid there. So we're going to look at this top layer moving in opposition to the rotator cuff underneath. The test we would use is what they call the Ober test. Briefly, if we're looking at the lateral greater trochanter, we see the anterior facet. This is the footprint of where minimus inserts. This is the footprint of where lateral facet medius inserts. And then right up high here, which is why we don't see it in this view, this is the second sort of thicker, stronger, more posterior band of medius. The posterior facet is largely just a big bare area where the bursa sits. So maximus sits very closely opposed over here. So what we need to do is make the hip move so that we can see if there's any lateral click occurring out here. So this is minimus, this is medius, lateral facet in red. This is medius, the second tendon, the posterior superior facet, and the posterior facet is just the bare area. So we're going to see something like this. So if we were on our left hip, we'd have the patient on their side, the left hip facing up because that's the affected hip, and we would see minimus, and then beyond the little bump in the bone where it transitions to lateral facet, we'd see medius, looking the same thickness both anterior, mid and posteriorly. And then we're going to see the maximus move like this over the top of the rotator cuff tendon. Okay, so this is what we see on ultrasound. We see the tensor fasciae latae anteriorly, the minimus in transverse, which usually looks thick and then tapers to a little triangle when you're in the transverse plane. This is the interval between minimus and medius, so it looks like there's no tendon at this point. This is our lateral facet medius, and you can see how overlying that is the gluteus maximus muscle. And all this thick white layer here, this is ITB or ITT. So here we are again. We're seeing now, we've transitioned to push our probe a little harder here, so we're seeing medius, the lateral facet of medius. It's quite a broad tendon and very thin. top left, ITT, and then our maximus. So you can see how the muscle inserts into the ITT. So I think you've all got your orientation there. This is one that's become tendinopathic. So this can be a cause for the click as well, is a tendinopathy or calcific tendinopathy. So we're seeing maximus transitioning to ITT, that's our top layer. Underneath that, this is the lateral facet of the greater trochanter, and we've got a big thickened medius at the anterior and mid portion, and then more posteriorly it's thinning out. If you're seeing muscle directly up against the femoral shaft here, we're not going to see the click. You're below the rotator cuff, so we're just seeing at this point vastus lateralis only. So the bone needs to have this little point for you to be in the right location to detect the click. This is a normal example first, and then I'll show you the patient that was symptomatic. So this is a normal movement of our ITT gliding over the rotator cuff. We can see the rotator cuff underneath. The bursa would sit here in between the two layers, as in the greater trochanteric bursa, or some people call it the subglute max bursa. It's all the same thing. So nice smooth movement. I think you get the idea. So you can lie them down and move the leg forward and back as if they're doing a freestyle kick, but the hip usually needs to be adducted. So as opposed to our iliopsoas, which we abduct away from the midline of the body, to see a lateral clicking hip, you often need to adduct. Okay, so here's our symptomatic patient. So this is a case of external snapping hip syndrome, or lateral clicking hip. We'll go through the landmarks where anteriorly we're seeing the anterior facet, then the lateral facet. So this is where minimus inserts, this is where medius inserts. The glute max would be over this part of the image. If you watch glute max, there's the anterior edge of it, and you'll see it quickly snap over. So the muscular part of the maximus is now come right forward to this point. I'll let you watch TFLs over here. So we see no muscle at this point, and during the movement, all of a sudden, bang, there's the muscle, and it's going to snap back off in a second. One more time. This is medius tendon sitting underneath, no muscle on top. There it is. So that's the lateral clicking hip cause, is the anterior edge of the gluteus maximus snapping over the gluteus medius tendon. Again, this is medius. There's the muscle snapping forward and snapping back off again. And in this case, it wasn't actually that there was any tendinopathy of the medius tendon underneath. They had an MRI, it was completely normal on MRI, just had this mechanical snapping sensation, which is highly annoying during his competitive sport. This is his normal side. We'll just watch this a few times. Maximus is back here. This is his lateral facet here. This is his anterior facet. You can sometimes try and reproduce the lateral click just by doing a butt clench, like squeezing your buttock together. You can see it sliding smoothly forward and back off the... I'll just run it forward again. Here it comes. So this is what it should look like. Maximus just glides over the medius. There's medius. And then glides back again. So have a look up what the OBER test is, OBER, and you might be able to reproduce this in your patients lying down, but as I said, we needed to stand ours up. If someone's had a fracture of the femur, they often use these intramedullary rods, and of course we need great big screws. And in this case, the screw was protruding from the lateral facet. So this is a transverse image on the right hip. Patients lying on their side, so this is superficial, this is the fat layer. We can see ITB from here to here. We can see minimus where it inserts. This is where medius would insert, so this would be tendon from here up to the first white line. And here the medius is thickened. We've got a great big screw protruding out through it. Back here would be maximus. In this case, we weren't actually seeing a snap over the screw. It just really wasn't moving normally at all and had a great big bursal thickening, inflammation and scar tissue between the tendon and the ITT. Okay, just a couple more cases to finish. When we're doing examinations of the anterior and lateral hip, If someone just had a pop sensation and pain, it might not necessarily be that the pop is repetitive and the click might have just been a once-off. So in the case of this young sprinter, we can see nice normal iliacus muscle in transverse. This is the iliac wing sloping down away in the right pelvis. And the corresponding left symptomatic side, we can see an echogenic muscle due to the interstitial bleed and a little defect there in the muscle, and it's starting to heal now. So there's the regions where the collagen fibres snapped, and we can see the healing response in the muscle. And the little bleed tracking here between your sort of lateral iliacus fibres and some of the sartorius fibres. This is AIIS, so something to be aware of. Now, in terms of references, there's lots of them. I will let you pause the video if you want to take those down. Here's the next one. Putzer, as I said, has a great description of all the anatomy. Flato is another good one here. This one just talks about endoscopic treatments for snapping hips. So obviously, mostly we try and manage things like this conservatively through stretching and remedial therapies, NSAIDs, and obviously a lot of them are just biomechanical. There are surgeries that exist though for, say, external snapping hip. The aim would be to loosen or lengthen the ITB, like in that previous case I was showing you. And obviously with the other iliopsoas related causes for snapping, there are arthroscopic procedures as well. So you could have a read of that Music article there.